Slideshow, please.
Okay, yes, I wanted to be sure the recording. Okay, so good evening. Good evening, everyone. We'll be continuing with the presentation on mitral valve disease. A few days ago, we saw the structure of the mitral valve, how it develops, what the orifice is. It's 4 to 6 centimeters squared. And we went through mitral stenosis. So we will be going through mitral regurgitation now for the next couple of minutes. So mitral regurgitation, as the name implies, sometimes is called mitral incompetence, but some would argue that even stenosis is a form of incompetence, right? It's not working as it should. So some shy away from it. Appears technically more accurate to say regurgitation than incompetence. But it occurs when the mitral valve allows reverse flow of blood into the left atrium from the left ventricle during systole. Sorry, this is an error. I'll correct that. During systole is when the left ventricle contracts, there is backward flow of blood back into the left atrium. It is more common than mitral stenosis, but it may coexist with mitral stenosis. And it could be primary from disease of the valve apparatus itself or secondary. In countries like ours, the most common cause of primary mitral valve regurgitation is rheumatic heart disease. While in developed countries, myxomatous and degenerative causes are more common. So what causes it? We've said it could be primary. Primary is generally said to account for about 2/3 of cases. Although I'm not sure if I'm too comfortable with that ratio, because I think we see a lot of secondary more in our practice, but you know. So it's due to pathology of the mitral valve apparatus, either the leaflets, the chordae, the papillary muscles, or a combination. And it could be from leaflet abnormality, like congenital mitral valve cleft, parachute mitral valve, double orifice, whatever. It could be rheumatic, where sometimes the leaflets, the chordae, they're all calcified, thickened and distorted and calcified. It could be from infective endocarditis having destroyed the leaflet or the chordae. And it could be from valvulitis from collagen vascular diseases like Marfan syndrome. Hurler syndrome is type 1 mucopolysaccharidosis from anorexigenic drugs. And we remember hypertrophic cardiomyopathy tends to be associated with MR, which is thought to be from an actual pathology of the mitral valve itself. So we could have caudal rupture due to resulting in flail leaflet from myxomatous degeneration in mitral valve prolapse or Marfan syndrome. We could have rheumatic caudal thickening and calcification. It could be from blunt chest trauma or trauma during surgery. So in an attempt to do balloon commissurotomy or balloon valvuloplasty that we saw as treatment for MS, we could cause damage to the leaflets and cause mitral regurgitation, or it could be spontaneous caudal rupture. Papillary muscles could also become abnormal, either from infiltrative diseases like amyloid and sarcoid, or more commonly from myocardial infarction. And as we discussed the last time, because of the blood supply, the anterior papillary muscle has a dual blood supply, while the posterior papillary muscle has a single blood supply. So it is more likely to be affected when there's mitral papillary muscle rupture. And it is said that what we mostly see is the partial rupture, because the complete rupture has very, very high mortality. So it could be secondary, also called functional, and this is said to account for about 1/3 of the cases, even though I tend to feel, I haven't seen the numbers, but in our environment perhaps more. And the valve apparatus itself is usually normal, but the mitral regurgitation occurs usually due to ventricular amocomal or atrial remodeling. So think of anything that can cause the left atrium or the left ventricle to dilate. It's a cause of secondary mitral regurgitation. So if it's in the left ventricle, when it dilates, it causes displacement of the papillary muscles. They're displaced apically and or laterally. Therefore, the leaflets are tethered. They're further separated apart at rest. So there's reduced closing forces, and sometimes they are not even able to co-opt, especially as many of these secondary causes that will give LV dilatation also cause LV systolic dysfunction. There might be dysynchrony. So the contraction of papillaries is also impaired such that the mitral valve leaflets are not able to co-opt properly. And in many of these secondary causes, like let's say in cardiomyopathies, especially like dilated cardiomyopathies, the jet may be central because it's the orifice in the center. The two leaflets are being pulled apart by the dilated ventricle, or it could be eccentric, in which case, like when we spoke about ischemic damage to the papillary muscle, is usually one. So the jet will be related to that. The regurgitation is related to the portion of the valve that is held by that damaged or ruptured papillary muscle. When the left atrium dilates, if there are preserved left ventricular dimensions, then it leads to annular dilatation. Okay, so it's the left atrial dilation that leads to annular dilatation, while left ventricle leads to displacement of the papillary. Of course, if there's annular dilatation, there will also be insufficient, the leaflets will be pulled apart again, and they cannot reach each other and co-opt and close the orifice during systole. So this is just a summary of the causes, from the leaflets themselves to the annulus to the chordae to the papillary. We could look at these in our time if we want to. I will speak about the pathophysiology, but I just wanted to put this pictorial representation. So in a normal heart, during the systole, the mitral valve is closed shut, and the contraction of the LV leads blood to go out through the aorta, whose valve is open. If we have acute mitral regurgitation, the left atrium is its normal size. It's used to handling a certain amount of pressure and volume. When acute MR occurs, it's suddenly faced with an enormous amount of volume and pressure that it's not used to. So this translates quickly into the pulmonary veins and pulmonary circulation. It gives pulmonary edema. So there's regurgitation both into the LA and the aorta. Now, in chronic regurgitation, the LV is usually dilated. The LA is also dilated because it has been accommodating this excess blood. So the elevated pressures are not as marked as in acute. And we have, because pressure is still lower in the left atrium compared to the aorta, where there's a lot of peripheral vascular resistance, blood is preferentially pushed into the left atrium, which kind of acts like a sink, and less of it goes out through the aorta. So we have decreased stroke volume, decreased cardiac output. But in general, what mitral regurgitation will cause is an elevation of left atrial pressure and volume, like we mentioned, reduction in forward cardiac output, like our picture here on the far right with the smaller arrow for aortic flow, and volume-related stress on the left ventricle, because the regurgitant volume, the regurgitant volume that goes into the LA comes back into the LV together with the new venous return. So the volume is particularly large. And but there are differences between acute and chronic mitral regurgitation, like I mentioned, mainly due to the left atrial size and compliance. In acute MR, you have a normal or whatever size of the atrium that it's used to, and the compliance is as it's used to. Suddenly there's high atrial pressure, high pulmonary venous pressure, and acute pulmonary congestion and edema. So this underscores how they present clinically. Also, there's marked decrease in forward flow because it's all going, much of it is going back into the left atrium, which can lead to hypotension and cardiogenic shock. So acute MR presents very dramatically. For the chronic type, the backflow of blood leads to progressive dilation of the left atrium because it keeps dilating to accommodate this blood. Remember, the atria are not, they can dilate easily sort of, they're not thick-walled, they're thin-walled. So the increased atrial size, it will increase atrial size and compliance. So it becomes larger and more compliant to be able to handle that pressure and volume. So there's, in the compensated state, relatively normal left atrial pressure and pulmonary venous pressure despite the large volume. And there's decrease in forward flow as well, like we said, because the blood will preferentially go into the lower pressure left atrium compared to the aorta. So initially, Frank-Starling mechanism will compensate with this large volume that comes into the LV, stretches the myocardium more and leads to increased force of contraction, like we saw during the session on the heart as a pump. So it maintains cardiac output, and in this stage, many patients would have minimal or no symptoms. They're going about with their MR and they don't even know. But when it starts to decompensate, yes, so because of that large volume, normal ejection fraction in especially primary MR is actually 60%. If they have less than 60%, then it's LV systolic dysfunction. So over time, the volume overload will lead to progressive left ventricular dilation, eccentric LVH, and systolic dysfunction such that no matter how much it stretches, it cannot pump with any more force than it is doing already. So there's a drop in stroke volume and cardiac output and left ventricular failure. And the left atrial dilation and volume overload will also lead to atrial fibrillation, could lead to atrial fibrillation. And we know that atrial fibrillation will further drop the cardiac output because that 20 to 30% that the atrium will contract and push into the ventricle so that it goes out, it's lost, and the diastolic time is also usually shortened because there's tachycardia. Still, this left atrium volume and pressure overload will eventually get transmitted to the pulmonary circulation and lead to exertional dyspnea initially, but even later at rest. And much so, vicious cycle, it gets to pulmonary hypertension, and pulmonary hypertension can give RV failure. So eventually they come with biventricular failure. So again, I'm putting this back here just to remind us all of that in acute, the high LA is the pressure in the LA is extremely high, while in chronic, it's not as high and it takes time before it compensates and they develop symptoms. So, okay, can we mute? All right, so the severity of mitral regurgitation and the ratio of forward cardiac output compared to the backward, so compared to the regurgitant one that goes back into the left atrium, is dictated by a number of factors. Of course, what I'm describing is a regurgitant fraction. The size of the mitral orifice matters because if could we have that muted? Thank you. So the size of the mitral orifice matters. If you have concomitant stenosis, it will influence the regurgitant fraction. The systolic pressure gradient, so between LA and LV, so differentiating acute and chronic. Systolic vascular resistance. So if there's resistance, a lot of peripheral vascular resistance, it will also further reduce the stroke volume, because if there's pressure on that end, then the blood will if there's pressure in the aorta, high pressure, the blood would rather flow back into the left atrium, which is easier because it's lower resistance. Of course, the compliance of the left atrium, like we mentioned, and the duration of regurgitation with each systolic contraction. So, duration of the cardiac cycle. So in essence, the formula for regurgitant fraction is defined as volume of the mitral regurgitant flow, that's back, and divided by the total stroke volume. So hemodynamics. Again, on the left, we have a normal flow. We have diastole, systole. We have the left atrial pressure, the A wave, the C, the V. and pressure in the aorta, and LV, which rises in systole but comes down and almost equilibrates with the left atrium in diastole. So here in MR, we have A wave, but because when the left ventricle contracts, blood goes back into the left atrium, so it raises pressure in the left atrium, such that we would usually have a tall V wave, which even merges with the C. So this is sometimes called the CV wave. We'll talk about the hard sounds later, but when this regurgitation is taking place, and it's throughout systole, usually for chronic MR, again, we would put some caveats to that when we, in a few slides, there's a hollow or pansystolic murmur. And sometimes, even because of the large left atrium volume that is coming into the left ventricle during diastole, there might be a small diastolic rumble. So how do they present? It's related to the acuteness, how acute or chronic it is, like we've seen in the pathophysiology, and the severity of the MR. Acute MR will present with features mainly of acute pulmonary edema, like we said, very dramatic, sudden onset dyspnea. They could also have hypotension and shock because the forward flow is suddenly greatly impaired. They could have really high pulmonary pressures with hemoptysis and all of that. While in chronic MR, they're usually compensated initially, like we've seen from the pathophysiology. So initially, they have this like latent, asymptomatic or minimally symptomatic period. Then when they decompensate, they start to develop dyspnea and fatigue, and later full-blown heart failure, mainly left ventricular failure, and subsequently RV failure from long-standing pulmonary congestion, pulmonary hypertension. Of course, they could also have features of atrial fibrillation. So what do we hear when we auscultate? Like we showed with the hemodynamics, there's a pansystolic murmur. It's usually high-pitched or blowing, as is described. But like I said, there are caveats. In acute MR, there's high pressure in the LA and decrease in pressure in the LV during systole. So as the LV contracts, the atrial pressure rises, and then they equilibrate quickly. So this might truncate the murmur. So instead of pansystolic, we could have the murmur being shorter. I think early or mid-systolic, right? Stopping before the end of systolic. So the murmur is dynamic. It increases with hand grip because we're increasing peripheral resistance. So there's more turbulence, and it decreases with Valsalva because we've decreased venous return. So kind of decrease the volume. And typically we know that MR murmurs radiate to the axilla. But if we have an anterior jet, rather than radiating to the axilla, it radiates to the sternum, to the base of the heart. So close to the sternum. And it might even sometimes be mistaken for aortic murmur. Okay. Please, I will mute the person with the mic on, and that means, okay, I've done that. My slides will stop moving and I'll unshare and reshare. Okay, so let me get to the slide we were on. Oh, yes, so anterior jets could be heard, yes, they could radiate to the sternum, to the base of the heart, so they might sound like they're aortic. It's an aortic murmur when it's not. And the posterior jet would move towards the axilla or even the infrascapular region, or even sometimes way back to the spine, depending on how severe it is. They might have a thrill, and we could have a diastolic rumble, as I've mentioned, because of increased flow across the mitral valve and diastole because of the large volume in the left atrium. The heart sounds, the S1 could be soft because, like we've said, the leaflets are not even coapting properly. Sometimes they're not even reaching each other to make the sound. So it could be pretty soft. And they could have widely split S2 because the aortic flow is reduced. The aortic flow is reduced. So because there's little blood going through, it could close earlier than the pulmonary, especially than the pulmonary, and we could have a loud P2. Of course, in chronic MR, an S3 is common, but less commonly we could find a fourth heart sound, especially in acute MR. So these are the auscultation findings, like we've said, between S1 and S2. This is systole, so we have a pan-systolic murmur, usually like the same intensity throughout. But if there is prolapse or some other acute, it could be mid-systolic, they say, yeah. S1 we've said can be diminished, but it could also be normal if it's mitral valve collapse, because then the leaflets are long enough. We could have a loud P2 and wide splitting of aortic and pulmonary components of the second heart sound. Then we could have an S3. I don't have a live worksheet exercise for this one. So how do we work them up? Chest X-ray would depend on the duration of the MR and the severity. So if we have acute MR, we could have features of acute pulmonary edema on the chest X-ray. If it's chronic, we could have cardiomegaly, usually with multi-chamber configuration. So the LV, the LA, the RV may all be dilated. We could have features of congestion with heart failure, upper lobe diversion, curly V lines, and all that. The ECG doesn't have any specific findings that are exclusive to mitral regurgitation. They would depend on, again, the duration and severity. So we could have LAE, LVH, atrial fibrillation, and if in cases like acute papillary muscle rupture, we could have features of the underlying MI that just occurred. So echo is the mainstay for diagnosis, to reveal the etiology, to grade severity, and TTE, transthoracic echo, is the first line imaging. We will start showing recommendations, guideline recommendations after this slide. Transesophageal will typically give additional information, especially when intervention is being planned so as to properly characterize the mitral valve apparatus. And there might be need for intra-op transesophageal echo. 3D echo can also be particularly useful, especially when intervention is being planned as well. So grading of the severity of the MR may be difficult because sometimes jets are eccentric, sometimes there are multiple jets, and secondary MR could be affected by loading conditions. Remember, even the murmur, where is it? We've said it increases with hand grip, which increases after load or peripheral resistance, and it decreases with Valsalva, which decreases venous return and preload. So it reflects in the flow of the regurgitant flow, the MR on echo. So acute grading of the severity will require measurement of multiple parameters. Transthoracic echo can also assess the effects of the MR. So if we already have chamber dilatation, and we could estimate, of course, the left ventricular systolic function, the ejection fraction, and we've already mentioned what is normal in primary MR, which is 60. We will measure the PASP, the MPAP, and all of that. So Okay, yes, we've said if they're compensated, then they should typically have left ventricular ejection fraction greater than or equals to 60. In primary MR, if LVF is less than 60, they already have systolic dysfunction. So what are the parameters that are used to grade this severity? There are a number of them. I will show the values that are used. Actually, part of the reason I wanted to get like step by step how to do this, but it was going to take a lot of time, and I didn't even have it would have like prolonged. I have 100 slides. It would have made the slides a lot more and took time. So I think we could learn these, or if there's any chief on the platform that knows these measurements well and can help us explain them, that would be appreciated. But we use the jet area measured as a percentage of the left atrium. Now, each of the methods has its own limitations. So that's why it's reasonable to combine, all the different parameters. Especially in eccentric jets or multiple jets, it could underestimate the jet area. The vena contracta, which is a jet width at origin, or we could use the effective regurgitant orifice area, which it's been shown to predict survivals. Yes, it's been shown to predict survival. So it affects outcomes, and it's less secondary in secondary MR. It's less accurate, sorry, in secondary MR compared to primary. The regurgitant volume, which is the amount of blood, let's just put it that way, flowing back into the left atrium. So yes, mitral inflow minus LVOT outflow, but we need to accurately measure the mitral valve and LVOT diameters. And we could use the time velocity integral to get that. I think the continuity equation, right? So there are measurements that use stroke volume, which may be more accurate if we have eccentric or multiple jets, because some of these other measurements have their assumptions. Then the regurgitant fraction, which I'd already showed the formula. So still, apart from after we've fully characterized the regurgitation and tried to grade its severity with 2D echo, plus minus the other echo modalities that we mentioned, we could do a stress testing, especially exercise echo, especially if there's disparity between symptoms and the findings of the resting echo. Of course, cardiac cath would allow us to measure the pressures and look at those pressure trations that we showed earlier. We could measure the pulmonary capillary wedge pressure, the LA pressure, and we would see the amplitude of the V wave on the LA pressure tration, which is might be some indication of the compliance of the left atrium. We have already said that we see a large V wave in primary MR especially, and it could merge with the C wave to give, that CV wave. In secondary MR, it depends. Sometimes the extremely dilated left atrium accommodates the pressure and the volume, and the left ventricle doesn't really contract properly, because we've said in secondary MR, most of the cases are due to any pathology that would cause LV dilation, plus minus dysfunction, or LA dilation. So the LV isn't even contracting properly to give that force enough to cause the large V wave. So they may look normal. Then cardiac MRI is also useful when echo is inadequate, especially if we have eccentric or multiple jets. And it's particularly useful to characterize the mitral valve apparatus in primary MR. So I should have showed this during the first part of the presentation for Emma, since we showed guidelines there. But still, I'm certain everybody in this platform is familiar, but I'd still like to revise. Of course, we know that there are classes of recommendation and the level of evidence that is used to make that class of recommendation. So most of the guidelines, at least both the two we use most frequently, the ACC-AHA and the ESC, would put the level of evidence beside the class of recommendation. This helps kind of with accountability. So it's not like this treatment was recommended because, you know, the company that makes it or whatever. And it improves transparency and all of that. So we know that class 1 recommendation is strong and it means do it. It's recommended, do it, or it's indicated. Class 2 means there's some conflicting evidence. In some instances, it was found to be useful, in others, maybe not as much, or there was some harm or whatever. But class 2B would mean that it should be strongly considered. Much of the evidence is in support of benefit over risk. Class 2B means there's some benefit, there's some risk, but it appears there might be more benefit than risk, or maybe about the same. So it may be considered, probably if a patient is not able to get the other treatments or is not a good candidate for the better recommendations. And of course, class 3 means don't do it. It may be harmful and it's not recommended. Then the level of evidence, the ESC has a simpler one, just level A, either from multiple randomized controlled trials or meta-analysis. B, meaning from single randomized controlled trials or large non-randomized trials. And C, from registries, retrospective studies, and expert opinion. While the ACCAHA kind of divided theirs a bit. So A, we know high quality evidence from multiple randomized controlled trials or meta-analysis, or for them, they say one or more RCTs corroborated by a high quality registry. Level B, they have BR and BNR. So one, BR is from randomized studies, BNR from non-randomized studies. Level C is, they have LD and EO, LD meaning limited data, and EO meaning expert opinion. So there are more details to this if we look at the guidelines. So this is from the ACCAHA. I didn't label because I used both the ESC, but just if you've noticed, the ACCAHA have their class of recommendation and level of evidence on the left side, and they use Arabic numerals. So 2 would be written as the regular 2 that we know, while the ESC uses Roman numerals. So 2 is II. But anyways, for the imaging that we talked about, TTE, class 1 recommendation, do it for all patients. TEE in patients that are being evaluated for intervention, or in those that TTE is insufficient or has had discordant information. We can do CMR when needed. We could do, where's the place for stress? Yes, non-invasive stress testing, stress echo, but also we could do stress nuclear, PET, CMR, and all of that. Then we can do intraoperative TEE during surgery. Now, this is the stages of, from here henceforth, I think I'll be taking the primary and secondary differently because the recommendations differ a bit. But as usual, the ACC staging of valvular heart disease is stage A, at risk, B, progressive disease, so in this case, progressive MR, C, asymptomatic severe, and D, symptomatic severe. Now, for those echo parameters that we mentioned, the numbers to take note for severe MR are the, where is it? Okay, regurgitant jet, remember we said jet area, so more than 40% of the LA. Vena contracta more than or equals to 7, regurgitant volume greater than or equals to 60 mils, regurgitant fraction more than 50%, so meaning greater than or equals to 50% of the left ventricular end diastolic volume gets pushed back into the left atrium, and effective regurgitant orifice area greater than or equals to 0.4 centimeters squared or 40 millimeters squared. Of course, without symptoms here, but here with symptoms. And C1 has normal left ventricular ejection fraction of greater than 60, and normal, so the LV is not that dilated, while C2 has LV dysfunction of LVF less than 60, and the LV has started dilating. Of course, D means they have symptoms. So the ESC rather just focused on defining severe. They didn't bother with the earlier like moderate or whatever. So, and severe for primary MR versus severe for secondary MR. So they put them side by side with a few caveats here and there. But again, the AROA, that's the effective regurgitant orifice area greater than or equals to 40 millimeters squared or 0.4 cm squared. Same thing. Regurgitant volume greater than or equals to 60 mil, regurgitant fraction greater than or equals to 50. So sort of similar to the ACC/AHA. But there's some caveats for the secondary MR. But if we insist we want to grade them as mild, moderate, or severe, then we could use these values. But again, for the severe, we see, similar cutoff values as as I previously showed from the guidelines. Yeah, so I hope maybe Prof. Chifokopi or Kweki are around, they could help us further explain how some of these measurements are taken. So how do we treat? For treatment, remember that it's multidisciplinary. Let me just pull up the slide I used for MS. Just a minute. So multidisciplinary, have your heart valve center or heart valve clinic with all of the specialists that are needed, including imaging specialists and cardiac anesthesia, all of that. Remember also the general principles we've said, that they should have, live a healthy lifestyle. We shouldn't ignore their comorbidities, especially those with MR especially the chronic MR would typically come with heart failure. So we should treat that. If they have coronary artery disease, blah, blah, blah. So all of this, I didn't want to repeat the slide again. Okay, treatment, is this where I am? Okay, no. So we could go through some of these details. I think I skipped this. This is for the secondary MR. So the grading of the secondary MR has some similarities with the primary. This is ACCHA, but maybe some slight nuance differences. We've gone through this already. So for acute MR, acute meaning, there's some sudden injury occurring to the valve or valve apparatus that leads to sudden MR. We've talked about its pathophysiology already. So as expected, it would present as an emergency, and their treatment would usually require surgery. We need to go fix the suddenly damaged valve. We could give supportive medical treatment while we're arranging for that emergency surgery, like giving vasodilators like sodium nitroprusside, which will decrease vascular resistance and may improve forward flow into the aorta. But we can't use this if the patient is hypotensive or in shock, which many of them might be. We could use inotropes if there is need, like dobutamine, or we could use intra-aortic balloon pump, which would decrease afterload and increase forward flow and increase the mean arterial pressure. But the mortality from acute MR is typically high because even with the best treatment, 30-day mortality rate is 20 to 25%. Now, for the chronic forms, which is more of what we see, chronic primary MR. Hello, can you see my screen, right? You can still see the screen. Please let me know.
Yes, please,
okay.
We can see it.
My network glitched a bit. So chronic primary MR, like we've said, is due to abnormality of the valve apparatus, but it's not occurring suddenly, So the primary MR is frequently amenable to surgery, and medical treatment has very limited role, just mainly if there's LV systolic dysfunction. So these are the recommendations from the ACC, AHA, and medical treatment does not even have any class 1 recommendation. But class 2A, meaning we should consider, giving, if they have systolic dysfunction, we can give GDMT. But if they do not have systolic dysfunction and they do not have hypertension, they are normotensive, there's no point giving vasodilator therapy. Some practices, some would give ACE inhibitors or ARBs to patients who are asymptomatic just because they have a primary MR, but this has been shown to have no benefit, so don't do that. Valve intervention is the mainstay of treatment for patients who meet the indication. So of course, it could be repair or replacement. Repair is preferred, and it may be surgical, like mitral valve prolapse. They have a particular type of surgery that is done to excise the redundant leaflet and stitch it back, or it could be transcatheter. And the transcatheter edge-to-edge repair using a mitral clip has gained popularity, is less invasive and all of that. And survival appears to be better with repair than replacement in general. But there are, some individual cases that might do better with replacement. Replacement is the last resort. And valves, we know, I will not dwell on this, can be bioprosthetic or mechanical with all of their pros and cons of durability versus the need for long-term anticoagulation with warfarin. Now, who should get an intervention in patients with chronic primary MR? Of course, if they're symptomatic. For most of the valvular heart diseases, we will see that once they develop symptoms, it worsens prognosis. So if they're symptomatic and they're in stage D, give them an intervention. If they're asymptomatic, but they have severe MR and have started developing LV systolic dysfunction, that's C2, give them intervention and all of that. So the class 1 indications are severe primary MR, either with symptoms or without. And then all of these other ones that we could consider, either asymptomatic patients or symptomatic patients that need other surgeries that, okay, should get surgery together with, maybe they need a cabbage or something like that. We can go through the details. So this is the decision-making algorithm. We have primary MR. It's severe as defined on that table that we saw. If they have symptoms, we want to decide on intervention, which could be surgery or transcatheter edge-to-edge repair, especially if they have high surgical risk. So we do the surgery and we prefer, okay. Yes, so they should have surgery at comprehensive valve center or private. So the repair tends to do better, have better outcomes in patients that have it at a high volume center. In the text, all of this was rather emphasized. Patients should have a repair at a high volume center where there's expertise. It's easier to do the replacement, I think, in most centers, but repair tends to have better outcome when done with the proper expertise. So what should we do with asymptomatic patients with primary MR? They don't have symptoms and they're not severe. So stage A or B, or even C1, B and C1, they don't have symptoms. We should follow them up with echo every 6 to 12 months. Then there is some emerging role for biomarkers like BNP, but I think this hasn't really, but it is a class 2B recommendation. So maybe over time, when it's properly studied, we'll come to know how useful it is. Then should they develop changing symptoms or signs, even if it's not yet their time for that scheduled 6 to 12 month surveillance echo, they should have echo to look for, progression and things like that. Now for the chronic secondary MR, which is, I think, what we see more frequently. So somebody with cardiomyopathy, ischemic heart disease, hypertensive heart disease, whatever, coming with secondary MR, medical treatment is the mainstay now. Medical treatment of the LV dysfunction and treatment of the underlying cause, where we have treatment for it, since the valve apparatus itself is usually normal. But there's some growing evidence for intervention with transcatheter edge-to-edge repair in highly selected patients. So class 1 recommendations, give them GDMT for heart failure if they're in heart failure. We already know treatment for heart failure. They should also be seen by cardiologists with experience in heart failure, and LV systolic dysfunction should be part of their multidisciplinary team. Should we intervene? There's no class 1 indication, at least according to the ACCHA, for secondary MR getting surgery. But we have class 2A, so we could consider in patients who have LV dysfunction, really bad symptoms, despite their optimal GDMT, perhaps the MR is contributing. And if we think they have appropriate anatomy and all of that. So we could do this. Also in patients who are undergoing CABG, they could also have mitral valve surgery in the same sitting, and some other indications, as you might see. So this is the treat decision algorithm for the ACCHA for secondary MR. Do they have LV dysfunction or not? If they don't, we should treat all of the arrhythmias and give them GDMT. If they don't improve, we could consider surgery, but this is class 2B. While class 2A, okay, they have LV systolic dysfunction, they've been given GDMT, they have symptoms, we've looked at their valve anatomy and it's good, then we could try transcatheter edge-to-edge repair. While if they're undergoing CABG, just consider repairing the mitral valve in the same sitting. Although it increases surgical time and there's some increase, peri-op complications with the longer surgery. Now, this is for the ESC. For primary regurgitation, primary MR, they're almost the same. It's just that the language is simpler. So they used fewer words. It's recommended when the results are expected to be durable in primary MR, in symptomatic patients who are operable and they're not high risk, in patients who are asymptomatic and have LV dysfunction. So it's a class 1 here. I think it was there too. Anyways, and all of that. Class 2A for patients that are asymptomatic and have preserved ejection fraction, but have AF and pulmonary hypertension, and we don't want them to progress. Like Prof told us during the last lecture, sometimes doing surgery earlier might, give more lasting favorable outcomes. So these are the other indications. So this is the decision-making algorithm from the ESC. Sort of somewhat similar. We can go through and identify the differences if we want to. Now for secondary, we give them GDMT. If they don't do well, we refer them to the heart team, optimize GDMT, give them CRT if needed. Remember, during the earlier part of the presentation, we said if they develop complete LVB or something else that worsens LV function, it also worsens the coordinated contraction of the papillaries and the coaptation of the leaflets. So if we expect that they would survive, so there's room for palliative care in the ESC guideline. If they won't survive, give them palliative care. If they will and they have coronary artery disease, we could consider surgery. This is the continuation. Okay. So all the way to either TER, giving them CABG and mitral valve surgery together, or just close follow-up, or palliative care. So what is the prognosis of mitral regurgitation? It varies with the etiology, as we've seen. It varies between primary and secondary, acute and chronic, and even the chronic. The etiology would most definitely influence the outcomes. Acute MR, like we've said, has a 30-day mortality of about a quarter of patients dying, even with appropriate treatment. Chronic primary MR has improved outcomes with surgery, especially with repair done in high volume centers. While chronic MR primary generally has better prognosis than secondary. Mainly the secondary MR, the prognosis is influenced by the underlying cardiac pathology. So somebody has advanced ischemic heart disease or, advanced heart failure with very low ejection fraction or whatever other pathology. But in general, the primary have 5-year survival of about 70% if they're asymptomatic, but it declines rapidly if they have symptoms, 3 to 4. While secondary MR survival, 2-year survival is about 20 to 30%. So really probably reflecting, this kind of looks like heart failure type survival. So that ends mitral regurgitation. We'll quickly take a look at mitral valve prolapse, which is one of the common causes of mitral regurgitation, even though I don't know how frequently we see it. So mitral valve prolapse is an abnormal bulging of the mitral valve leaflets into the LA. Leaflet or leaflets, could be both, could be one, could be part of the leaflet. There's usually redundancy with loose myxomatous tissue, replacing the normally dense collagen and elastic matrix. This is typical for, I'll show the etiologies, for Barlow syndrome, is usually accompanied by MR. And it is a common echo finding. Reports from developed countries say that it's seen in 2 to 3% of the general population on 2D echo. And the many are asymptomatic. So it could be an incidental finding on echo. 2 to 3 is like 3 out of every 100 people. So that's pretty common. And it's a common cause of primary MR, like we've said earlier, in high-income countries. It affects females more than males. So this is what I mean. This is a pathology specimen. The mitral valve, this mitral valve leaflet has ballooned, into the left atrium. It's loose and it's going where it shouldn't go. When we do a plaques view, this is what we see. I'll speak about the measurement. When we draw an imaginary line across the mitral annulus, the mitral leaflets are bulging into the left atrium above this line, about 2 mm. I'll show the echo assessment. So it could be primary without any associated connective tissue disorder or collagen vascular disease. And this primary could also be familial, which may have autosomal dominant inheritance with variable penetrance, or it could be sporadic. And there are 2 main types. There's Barlow syndrome or Barlow disease and fibroelastic deficiency. The Barlow disease, they have bileaflet mitral valve prolapse. So both leaflets, and the leaflets are thickened and floppy and a very large annular diameter. The normal diameter is about 10 centimeters. Diameter, not area. So they have a very large mitral annular diameter, and they can have abnormally elongated chordae, which allow the leaflets to, bulge into the LA. There's a lot of room for it to move. While the secondary is associated with connective tissue and collagen vascular diseases like Marfan. So this is differentiating the Barlow and the fibroelastic deficiency through age and the size. This, you see, the Barlow disease has much, much larger annular size. And we could look at these other differences. But the Barlow has diffused thickening of the valve, while the fibroelastic deficiency is more localized. Barlow occurs in younger, at least less than 60. They have a long, hollow, kind of almost hollow systolic murmur and all of that. So how do they present? Many are asymptomatic and will just be fine on echo, hence that 2 to 3%. Or they could be found due to a mid-systolic click or an MR murmur. So they have an MR murmur and they go for evaluation, and it's found that they have primary MR from mitral valve prolapse. The mid-systolic click is thought to correspond to the sudden tensing of the mitral leaflet or chordae as the leaflet is forced or prolapses back into the LA. And while the murmur is an MR murmur, flow through the incompetent valve, and is usually mid to late systolic. Okay, and they are altered by dynamic auscultation. So if we decrease the LV volume with EG standing or Valsalva, we decrease aortic impedance and increase contractility, and the click occurs earlier and the murmur is louder. If we increase LV volume, then the click occurs later and the murmur is softer. So presentation may also be of the underlying connective tissue or collagen vascular disorder. And if they have symptoms, it's usually from the MR. So we've just done MR, so they could have those symptoms. Or they could have symptoms from complications. So rarely we could have IE, arrhythmias, or thromboembolic events, because that flabby, floppy leaflet could house a thrombus and give thromboembolic events. Of course, they could present acutely, like acute MR, like we just discussed, due to sudden rupture of those elongated chordae and the subsequent flail leaflet. And the flail leaflet would be either one, anterior or posterior, with sudden severe MR, sudden rise in LA pressure and pulmonary edema, as we've previously described. And in patients who had already been known to have the mitral valve prolapse, and there's a characteristic of their murmur, the quality and radiation of the murmur changes suddenly with this flail leaflet. So diagnosis is usually with 2D transthoracic echo, like we've said. If we, that image I showed, if we draw a line across the annulus, then the leaflet is displaced by greater than or equal to 2 millimeters into the left atrium. Above that line, there might be thickening of the leaflets. We should look for MR. We should rule out rare causes like infective endocarditis, which could cause secondary valve damage and prolapse. We should look for thrombi and look for features of, so just evaluate as it is a chronic MR. In addition, in them, CMR, cardiac MRI, can reveal late gadolinium enhancement and others. So they might have more extensive like fibroelastic issues. We should also try to rule out connective tissue disorder. So, okay, I put this picture earlier, so I'll go back to it. So we should evaluate them as per primary MR, like we previously did. And the prognosis is generally good if they do not have complications. But if they have severe MR with dilated chambers, then they could present and have all of those risk factors as such. And when flail leaflet develops, they have a small risk of sudden cardiac death. So these are just some other congenital anomalies of the mitral valve. We could have a congenital MS, mitral valve prolapse, which is already treated, and parachute mitral valve, which they have a single fused papillary muscle. So the mitral valve leaflet kind of looks like a parachute, and it can give MS or MR or both. And when they do surgical repair, they divide the mitral valve, the papillary muscles, and try to kind of fashion anterior and posterior leaflets. So this is just differentiating true parachute mitral valve, which here in the middle, if you can see my cursor with the single papillary, this is normal, versus parachute-like and other causes that may look like parachute. So that ends the presentation. Thank you. Okay, I didn't talk about IE prophylaxis. We have done IE prophylaxis previously. You know, we did when we treated MS, and we also had a guideline lecture previously. So the indications for IE prophylaxis are as previously, mentioned. If I might just add a word on that. In the past, IE prophylaxis used to be more liberal. There were more people that were considered eligible, and there were more procedures that were considered eligible. Over time, it was found out that even activities of daily living, like chewing or brushing one's teeth or flossing, can lead to bacteremia. So if these day-to-day activities lead to bacteremia, that may not be much different from like urethral catheterization or cystoscopy, then it was decided that there was really not much need to be given for. So that's why gastro and urinary tract procedures were removed. Of course, the dental was also streamlined to, if we're manipulating gingival apical tissue and blah, blah, or cutting the oral, breaching the oral mucosa, and the categories of patients that were considered eligible were also streamlined. Of course, we've said, so yes, this is the ESC, this is the AHA, but cyanotic congenital heart diseases feature, as well as patients that have prosthetic valves or any prosthetic material. And yes, so of the three guidelines, there's the NICE, that's the National Institute of Health and Care Excellence in the UK. Theirs are the most strict guidelines, and I'm not sure a lot of people use them, but theirs are the most strict. they do not recommend antibiotic prophylaxis for anybody. They recognize high-risk individuals. They say, you know, maintain oral hygiene. When you're doing surgery, maintain asepsis and all that. And if they have an infection, treat it early. But they do not recommend giving then, of course, the ACC, AHA, and the ESC with their slight differences. So thank you. Any additions, comments, contributions, and yes, those measurements, if we could have any of our chiefs help us explain what, you know, how to go about doing them and all that. Thank you.
Thank you very much, Dr. Rukaiya, for a very lucid presentation. Please, the floor is open for questions and comments. I don't know, Chief Okopi, please, are you still there, sir? Chief Okopi? Okay, I can't see me. Prof, sir? Oh, they are both not here, but please, if there's anyone of our chiefs that can help us with these parameters, kindly help us out. Thank you. In the chat box, Dr. Lalekon is making a comment, or is asking that what view of TTE demonstrates greater than 2 mm displacement into the LA. I think this is as concerns MVP.
Sorry, I muted myself. It's the plaques view, parasternal long axis. I think okay, my slides have stopped moving. Let me just wanted to show the image again.
It is good plaques view actually. Please, more comments and contributions before we move to the next session. Thank you.
So it's the parasternal long axis view. This is just a schematic drawing of it.
Dr. Ruki, it seems there are no further comments and questions. Unfortunately, Dr. Okopi is not here. Have also left. Maybe they're busy.
Yeah, possibly. So
yes.
I can stop sharing, yeah?
Yeah, it's because of those measurements that you talked about, that if we can get more clarification.
Yeah, I thought the class would benefit from some, you know, more extensive explanation of.
Yes.
But they're definitely cumbersome measurements to make, you know. Some are calculated using a number of other parameters and all of that. But maybe we could note it. Yeah, we could note it and, you know, get more from Prof or whenever he's available. So I'll stop sharing and I'll end this recording. Can I?
Yes, and you will now commence the next recording for us for the session, ma. Thank you so much.
All right, just a minute.
Okay, so welcome back everyone once again.